Thank you, Caitlin. Malnutrition is, as you know, a topic very close to my heart, and I found your call to action on pragmatic diagnosis and treatment very helpful. What I find particularly striking is the high incidence of malnutrition observed across all pediatric disciplines, which makes it really relevant for all healthcare professionals, especially the long term impact of malnutrition later in life given. Oral nutrition supplements have proven safe and efficient for this purpose, and these have been reported to be relevant from a health economic perspective, with reports on lower antibiotic use or shorter length of hospital stay. Next, we have two lectures back to back on clinical benefits of symbiotics on the dietary management of infants with cow's milk allergy. The first lecture is given by Dr. Rosan Meyer about living with cow's milk allergy, the impact on children's life. What does the latest information tell us? Dr. Rosan Meyer is an internationally renowned pediatric dietitian. She's an honorary senior lecturer at Imperial College London and visiting professor at KU Leuven in Belgium. The lecture of Professor Nowak Wegrzyn is about the clinical benefits of symbiotics for infants with cow's milk allergy. Professor Nowak Wegrzyn is a professor of pediatrics at the New York University School of Medicine and the director of the Pediatric Allergy and Immunology Division at New York University Langone Health.
I am going to talk about a topic that I feel very passionate about, and it's also a topic that I was very privileged to do collaborative research on over the last 2 years. The topic is the living with cow's milk allergy and the impact on children's lives and what the new information tells us. As per other lectures, I'd like to start off with my disclosures, which primarily include academic lectures like these, but I'm also part of some of the allergy boards and could have a research grant as well. I think at the beginning of a presentation, it's always good to kind of focus you on what are we trying to achieve today with the objectives. So I am trying to discuss today in the presentation the impact of cow's milk allergy on the lives of infants and young children and share some data, existing data and really new data with you, and also to explore the acute allergic symptoms, but in particular the wider burden, thinking about the immune function, the health outcomes and infection, and also healthcare outcomes as well as quality of life. I think it's good for any of you listening to a presentation like this to think about a clinical case that makes a discussion like that very much applicable to our practice. This was an email that I've received from one of my parents. It is of a 9-month-old boy with a challenge proven non-IgE mediated cow's milk allergy. And I am going to read out the email just to highlight a couple of areas. So the mother said, "Thank you for seeing us last week and saying, I hope you do not mind me contacting you again. I'm not sure what to do anymore. It's only October and he has had his fourth cold. Every time he has a cold, he does not sleep and his eating is awful." She's then asking, "Is this normal?" I'm also struggling to expand his diet as you suggested, because my standard advice, like anybody's advice, would be if it's only cow's milk that we're eliminating, then we want to bring the other allergens in as quick as possible to expand the diversity of the foods from an oral motor perspective, sensory perspective, and also for based on the evidence on microbiome diversity. Mom then said, he has not tried egg, wheat, and peanuts yet. He's now 9 months of age, and I'm seriously worried. I just do not have a gap when he's healthy enough to try one of the allergens, because part of my advice also is to try to introduce the allergens when the child is healthy so that you have very clear symptoms if they were to develop. Additionally, he has become seriously tricky to feed and wants to feed everything himself, often spitting out even his safe foods. I have asked my GP for help, but as he is growing well, they do not seem to worry. Please help. I'm so tired and I feel this will never end. So, also, just as explanation, within the UK setting, the first port of call from a medical perspective would normally be your general practitioner, and we have health visitors as well. I think all of you can identify with an email like this. But I think the areas that I want to highlight, which I've underlined, is the frequency of coughs and colds. The fact that these coughs and colds, like with any other children, have a knock on effect of sleeping and also eating. In addition to that is the pressure and the stress that is on the parents to expand the diet, because they do understand that having one allergy possibly increases the risk for another allergy, so wanting to get more foods in. And then also the concern that the child is getting more picky and more tricky when it comes to eating. This experience that I'm sharing with you from an email has also been highlighted in a recent online assessment of 64 parents of children below the age of 10 years, where a lot of times we think it's more the anaphylaxis type reactions that create the worst of the burden of the parents. This questionnaire based survey indicated that parents of children with cow's milk allergy have the most frustrating journey, feel most socially limited, are really most worried about their child, most wanting to disappear from a social perspective, requires most planning, and causes most anxiety. So, what you're hearing in the email is also confirmed that in cow's milk allergy, the burden on the families is huge. In addition to that, you heard from the email this absolute frustration. My child can't expand the diet. I want to expand to peanuts and to egg and to the other foods you've wanted, but I'm not finding a window of opportunity because my child is unwell. There was an amazing study published very recently, hot off the press, which looked at the health related quality of life in regards to introductions of foods at home. And they've had a robust number of children, of 171 children, and looked at the performance of home introduction of foods, where it was not performed. And of course, you always have those that are lost for follow up. And you can see that those where was not performed, there was the fear of parents, apologies, and fear of the child as well, and the aversions and the concern for allergic reactions. And all of that, and that category where the home introduction had not occurred, was linked to a low health related quality of life. So we now know it's not only the fact that you've got a child with an allergy that you worry about the reaction, but the fact that you can't expand the diet and the worry about reactions of new food introduction leads to a low health related quality of life. Now, this comes on top of the symptoms that children with cow's milk allergy experience. And I'm talking to a group of healthcare professionals that know the symptoms so well, the symptoms which vary between the digestive system, respiratory tract, the skin, and general symptoms. But actually, nobody really talks about infections. And these infections can include increased gastrointestinal infections, respiratory infections, ear infections, uh, and more skin infections. That's on top of your normal cow's milk allergy symptoms. In the past, these have been poorly studied, but I think for many of us, our observation, which can be seen as very biased, is that in the population that we see with cow's milk allergy, we see more infections overall. Now, what we have done, and I'm going to hover a little bit around this study, it's based on a retrospective observational study looking at the THIN database. The THIN database is the Health Information Network. It's a UK-based network based on 2.9 patients' active data, so this is data that's constantly growing, and based on over 360 general practices data. And in terms of research, one can gain access to this database. Now, we have gained access to this database looking at children with cow's milk allergy. And we recruited almost 7,000 children with cow's milk allergy and without cow's milk allergy. I want to spend some time on the inclusion criteria and exclusion criteria because that's really important. The question we often get is, how did you define cow's milk allergy in a database? So, of course, we included both male and female, but then in terms of cow's milk allergy, there are codes for cow's milk allergy, but we've also included children where there was a hypoallergenic formula, and I use the abbreviation HAF, in the last 5 years. And this formula needs to be prescribed below the age of 12 months at first prescription, and this patient should have received this prescription for at least 3 months, assuming that there has been a challenge, therefore, a reintroduction, and therefore there's a continuation of this hypoallergenic formula. And also, we looked at complete databases. Now, what we then added to the exclusion criteria, because many of you would say, well, there are many diagnoses where you would use a hypoallergenic formula for different reasons. So we excluded metabolic conditions, intestinal failure, patients with neck, cancer, malignancies, tumors, cystic fibrosis, CP, chromosomal abnormalities, and other medical prescribed nutrition not indicated for cow's milk allergy. In theory, it does mean there may have been children that we've picked up that have not been, we could not exclude. But I think our numbers are robust enough with having almost 3,500 children with this inclusion and exclusion criteria that we could recruit for this study. Now, what we really looked at within this study is the clinical burden of cow's milk allergy. And we looked at the number of infections over the 4 years and 11 months, so almost 5 years. We looked at GI infections, and under GI infections, I've put on the right side what we've included, which is, of course, your viral and bacterial gastroenteritis, Campylobacter, diarrhea, vomiting caused by suspected infections. We looked also at skin infections, which is skin and subcutaneous tissue infections, respiratory infections, which is primarily upper respiratory tract infections, acute tonsillitis, and then also ear infections. And it was reassuring for me to see that our data found that in all categories of infections, children with cow's milk allergy had more infections documented in their notes. And the reason I found it reassuring is that it really reflected what I saw in my clinical practice. Now, a lot of people then ask me and say, well, has it been documented before, for example, in regards to ear infection? There are not that many studies, but if we start with ear infections, there's a very nice Finnish study. They also have a governmental or national healthcare based system there, and they looked at children that were part of the public insurance database with documented cow's milk allergy. From these, they only included the children with a confirmed, so a challenged cow's milk allergy that was still within the area. So that was only 56 children, and to those, there was a questionnaire sent. Now, first of all, of course, we acknowledge within questionnaires that it is also that diagnosis might not be as accurate, but nevertheless, these were sent to those families in regards to specific otitis media. Now, in those children where there was no respiratory atopy, there was no significant difference between the controls and cow's milk allergy. And now, before you question the numbers of 180 when we just recruited 56, this meant the total number. So within that group, it was 29 cow's milk allergic children, and the rest were controls. But what was very interesting is those with respiratory atopy, which include your 80 patients in total, and part of the cohort was cow's milk allergic, there was a significant difference between those with recurrent otitis media and adenoectomies and ear problems. Now, following that, there are several other studies, and there's one systematic review that was more recently published in 2021 that looked at recurrent ear infections in children with cow's milk allergy and found an observational studies were identified. But the primary problem was, whilst they identified that that recurrent ear infections occurred, the data was heterogeneous. and the methodology was so different and different patients were included. And so the results found in that systematic review did not allow for researchers to find a correlation between cow's-milk allergy and the development of recurrent ear infection. But I think there is data there to say it might that there might be an association. What about cow's milk allergy and respiratory infection? So we looked in our database, which was retrospective, and we found that in our non-IgE mediated food allergic children, 67% of children had frequent respiratory infection. We did not have a control group, so we could not compare it to a control group. Interestingly, in 2006, apparently, in a prospective study looking at 117 children during spring with allergy. Now, I just wanted to say out of that, 46 were allergic, but it was not just cow's milk allergy, it was all allergy, with an average age of around 4 years of age. They found that allergic children had significantly higher number and longer duration of respiratory infections. Now, for me, this is quite telling. Look at the days. It's 8.92 days on average they took for the duration of the upper respiratory tract infections, where those that were non-allergic were 4.85 days. So almost half the time for the non-allergic children. There was also a wonderful publication followed by a group led by Alessandro Fiocchi, where they acknowledged that whilst respiratory infections are documented, very limited data existed. But some studies did acknowledge increased rates of respiratory infection. They also had discussed that there was a predisposition to atopy to have a delayed maturation of Th1 responses during childhood, which then may increase the risk for infections within the first year of life. Now, the increased respiratory infection was linked within that review paper to a variety of factors: the number of siblings, C-sections, nursery attendance, older maternal age, mode of feeding, and socioeconomic status. And that kind of links very nicely into the hypothesis around the microbiome. Here, we also can see that breastfeeding has many non-nutritive factors, including HMOs and also probiotic effect and a gold standing towards the microbiota. We can see that it can protect against infections, in particular gastrointestinal infections and also gastroenteritis and also otitis media. And you can see on the right, it's exclusively breastfed, but you even have seen some effect on those who are partially breastfed as well. Now, the increased infections, we wanted to see what the health economic burden has got. As I've already explained, the methodology, it's the same methodology as the study by Sorensen. It's the same database of almost 7,000 children, so almost 3.5 with cow's milk allergy and almost 3.5 without cow's milk allergy, with the same inclusion and exclusion criteria. And within this data analysis, we looked at the cost for hypoallergenic formulas, dermatological medication, anti-reflux medication, inhalers, adrenaline, antibiotics. And we looked at the health contacts of dietitians, GPs, pediatric allergists, hospital admissions, which is possible through this database because it's all coded. And it doesn't come as a surprise, knowing the data that these children have more infections, that the difference in cost per person year in cow's milk allergy is significantly higher than those without cow's milk allergy. Within the UK health system, and we used cost based on the UK cost, which is standardized, you can really see what a dietitian would cost, what a tin of a hypoallergenic formula would cost. You can see that is marked difference. It's almost £1,560 versus £178 if I rounded up for cow's milk versus non-cow's milk. And it's very much explained by the prescriptions, and you can see in all domains, antibiotics, anti-reflux, dermatologicals, inhalers, and adrenaline, all of them, the prescriptions were significantly higher in the children with cow's milk allergy versus those without cow's milk allergy. It therefore does not come as a surprise that the children who had cow's milk allergy had significantly more contacts, that includes dietitian contacts, specialist contacts, hospital admissions as well, in comparison to those without cow's milk allergy. I think I want to start wrapping this up, but everybody knows the allergic march, and I'm using the published non-allergic march that we've published now in 2019, where we also talk about the non-IgE mediated march, but bringing in in that the asthma, rhinitis, and also the functional gastrointestinal disorder. I'm using the simplified version here, where you can see really asthma coming in, rhinitis coming in, and also the EOE coming in a little bit later. But I think we do need to start thinking within this allergic march also about the complications of infections. And one motivation to help and to manage these children better is really to think about how can we impact the allergic march earlier on so that the infections can reduce also as they progress through the allergic march. So in conclusion, I hope I've shown you very well the recent thin database, 2 studies where we looked at the cow's milk allergy and the impact on respiratory, skin and gastrointestinal infections, showing you that there is a higher burden there. This has a significant health economic impact, and the association with increased infections have been reported by other studies. We do, however, need to do further research, and I think all of us are motivated now when we do studies on cow's milk allergy to include also concomitant infections there. Cow's milk allergy significantly impacts on the quality of life and also impacts on the delayed expansion of diet, which of course is affected by the frequent infections that they have, because to find a window of opportunity where you can challenge them or reintroduce big allergens can be quite challenging. And most importantly, I do think we need to now consider the immune system further, which complicates the allergic march in light of the data of showing more infections. Thank you very much. And I'm going to now hand over to my colleague Anya to wrap up this session. Thank you very much.
Thank you, Rosan. It is my great pleasure to be discussing clinical benefits of symbiotics for management of infants with cow's milk protein allergy. And this topic is particularly important for me because as pediatric allergist who specializes in food allergy, I really think this is a very important area. My disclosures for this presentation, I receive an honorarium from Nutricia, and I was a site PI for the multi-center international clinical study, PRESTA study, that investigated amino acid-based formula with symbiotics. I have 2 objectives for today. I want to describe the role of gut microbiota dysbiosis and how we can modulate gut microbiota in infants and children with cow's milk protein allergy, and to describe the evidence of the clinical benefits of symbiotics in the dietary management of cow's milk protein allergy, with emphasis on randomized clinical trials and latest real-world evidence. So, as pediatrician, I'm very acutely aware that early life is a critical time for development of the immune system, as well as the sort of establishment of a healthy gut microbiota, and in line with the developmental origins of health and disease theory, the first few years of life or even during pregnancy can program the future for future health or immunologic disorders, and not only allergy but autoimmunity. The first, the period of infancy and childhood that we'll be focusing on is really critical, but of course, immune system and gut microbiota can undergo changes also throughout the lifespan until late adulthood. So we all agree that breast milk is human breast milk is the gold standard in nutrition for infants. And very important role of human milk is protection that it affords from infectious diseases. So there are many components of breast milk that protect infants from infections such as gastrointestinal infections, otitis media, respiratory tract infection, as well as viral infection-induced wheezing. And this protective effect persists for several years after the discontinuation of breastfeeding. And this has been attributed to the presence of secretory IgA antibodies in breast milk that contribute and other factors that regulate gut permeability. There are also antimicrobial factors that are important for gut maturation and development of the innate as well as adaptive immune responses. Those include cytokines and growth factors. There's also lactoferrin in breast milk that is blocking inflammatory cytokines. There is lactose that acts as conditional prebiotic, and importantly, human milk oligosaccharides that promote healthy gut bacteria development and also compete with microbes for attachment to mucosa, and in that sort of through that exclusion protect against infections. Multiple lines of evidence have shown that infants with cow's milk allergy often have an altered gut microbiota compared to healthy breastfed infants. And importantly, this has been shown in infants who are symptomatic, but also in prospective studies, abnormal colonization could have been detected before development of cow's milk allergy. So it sort of sets the stage for abnormal development of the immune responses to cow's milk. Studies from my colleague Kirsi Jarvin and Seppo have also shown that the milk of mothers of infants who go on to develop cow's milk protein allergy have different composition of human milk oligosaccharides, suggesting that even in breastfed infants there could be a differential outcomes determined by the composition of the breast milk, pointing again to importance of the human breast milk components. Healthy breastfed infants have a predominance of bifidobacterium species, Escherichia coli, Faecalibacterium prausnitzii, and Lactobacillus species. In contrast, infants with dysbiosis, they are more likely to possess adult-like pathogenic bacteria such as Enterococcus faecalis, Methanobrevibacter, Clostridium difficile, or Campylobacter. So for the purpose of this presentation, we could agree that breast milk is the ultimate symbiotic. So it's not only the gold standard for infant nutrition, but it's also a gold standard for a symbiotic. Because breast milk, in addition to human milk oligosaccharides, also contains live bacteria, so it's not sterile. And as mentioned before, lactose, and all of those components stimulate gut microbiota and immune system development in a healthy manner. And until recently, hypoallergenic formulas that have been used for the management of cow's milk allergy lacked these microbiota stimulating factors. So paradoxically, infants that were in most need of help from breast milk or from formula were actually deprived of those beneficial components. So obviously formulas, hypoallergenic formulas, both extensively hydrolyzed as well as amino acid-based formulas, are sterile, don't contain any bacteria, they don't contain any oligosaccharides with prebiotic effects, and there is very small amount of lactose present in extensively hydrolyzed formula, but not in amino acid based formula. So infant feeding for infants with cow's milk protein allergy was definitely removed, from the natural breast milk protection that could be given to them if they were continue to breastfeed. But the new generation of hypoallergenic formulas have been developed, and this innovation has been going on for a long time before those formulas were introduced into clinical care. The formulas I'm talking about today are formulas with symbiotics, so symbiotic blend of pre and probiotics. So pre and probiotics together are referred to as a symbiotic. And the goal of that innovation is to mimic the components of human milk to specifically target gut microbiota dysbiosis. So prebiotic in those formulas is a mix of short-chain galacto-oligosaccharides with long-chain fructo-oligosaccharides or short-chain and long-chain fructo-oligosaccharides. So those oligosaccharides mimic the level and functionality of human milk oligosaccharides, or HMOs. Their use have been supported by more than 30 clinical studies in infants. The prebiotic that is present in those formulas in symbiotics is Bifidobacterium breve M16V. It is the most common, so Bifidobacterium breve is the most common species in human milk, as well as in the gut of healthy breastfed infants. So again, it was carefully selected. Also for its ability to reduce allergic responses in preclinical and some clinical studies. What's even more importantly, it has a long history of safe use, even in premature infants. It is developed or produced in a manner that it makes it free from the main food allergens. So it's safe for infants not only with cow's milk protein allergy, but also with multiple food allergies. So the name symbiotic describes the synergistic effect of the pre and probiotic that target the gut microbiota dysbiosis. So here's the overview of nutritious clinical studies in allergy management with symbiotics. And majority, 2 studies were conducted with extensively hydrolyzed formula, and 4 studies have been done with amino acid formulas, with 1 done in healthy infants and 3 clinical trials done in infants with cow's milk allergy, both IgE as well as non-IgE mediated. And those are good size clinical trials, and we'll delve into them in more detail. The 4 clinical trials randomized clinical trials demonstrated safety of formula with symbiotics and tolerability, and importantly, equivalence to the formula without symbiotic in terms of the supporting normal growth. And you can appreciate that both extensively hydrolyzed as well as amino acid based formulas were included in those studies, and all of the studies had Brave M16V as well as a different blend of the oligosaccharides. So the primary endpoints of those studies or outcomes of special interest were growth and safety. So the primary endpoints were met, and the studies have shown that formula with symbiotics supported normal growth and was safe and was well tolerated. It had additional beneficial effects such as improvement in constipation and presence of dry stools. It also contributed to improvement of skin eczema, skin symptoms in a subgroup of infant with IgE-mediated cow's milk allergy. And even with asthma, with lower prevalence of asthma-like symptoms and asthma medication at 1-year follow-up. So those are very exciting findings, which were the secondary outcomes. And those were attributed to the potential to rebalance the gut microbiota towards the more healthy and breastfed infant-like. So now moving on to the studies with amino acid formula with symbiotics. The studies again were focusing on safety and tolerability as well as growth equivalency with the traditional formula. And the studies have confirmed that formula indeed with symbiotics did not lose any hypoallergenicity, was safe and well tolerated, and it supported normal growth in healthy infants as well as in infants with cow's milk allergy. So first studies were done in healthy infants, and then based on preliminary data, favorable data, the formula was introduced to cow's milk allergy. The secondary outcomes and exploratory and safety outcomes showed that in all of those trials was that another beneficial effect was that formula with symbiotics protected infants from infection. So fewer infants experience infections at a lower percentage that was treated with systemic antibiotics. And we know that this is another factor that contributes to dysbiosis. Fewer had ear infections and a use of anti-infectives in a second study. And then in PRESTO study, there were fewer infections and hospitalizations. And again, amino acid formula of symbiotics was also shown to affect the gastrointestinal manifestations, such as infants had improved stool consistency, color, and sort of more resemblance to stool of healthy breastfed infants. And importantly, there's also a reduced need for medication to treat functional gastrointestinal disorders. Similarly to extensively hydrolyzed formula, amino acid formula also resulted in lower use of dermatological medication for eczema rashes in those infants. And those studies, the 3 randomized clinical studies, actually showed that feeding with formula with symbiotics resulted in rebalancing of the gut microbiota. And as mentioned before, this first study was a mix of IgE and non-IgE mediated cow's milk allergy. The second study focused on non-IgE mediated cow's milk allergy, and PRESTO was included infants with IgE mediated cow's milk allergy. In all 3 studies, there was there was an improvement in amount of bifidobacteria and decrease in a representation of potentially adult type pathogenic type bacteria. So feeding a formula of symbiotics moved or shifted the gut microbiota towards the composition that is present in the healthy breastfed infants. And in one study, this effect was observed for up to 26 weeks after discontinuation. Analysis of adverse event of those randomized clinical trials with amino acid formula symbiotic consistently showed reduction in infections and antibiotic usage. In the first study, there were fewer infections, use of antibacterial for systemic use, specifically amoxicillin, which is the most commonly used antibiotic, oral antibiotic for treatment of infections in the first few years of life. And you can appreciate that the rates in the blue bars, which represent traditional formula without symbiotic, are much higher for all of those parameters in all 3 studies compared with amino acid formula with symbiotics. The second study showed fewer ear infections and use of anti-infectives. And finally, PRESTO study showed fewer severe infections requiring hospitalizations. All of these studies investigated amino acid formula with symbiotic with BRAVE M16V. In PRESTO in particular, which was a large multi-center international clinical trial, we have observed that fewer infants in the symbiotic group were admitted to the hospital which is considered a serious adverse event with particularly gastrointestinal infections compared to those treated with the conventional formula without symbiotic, and this was statistically significant. So gastrointestinal outcomes are also were of interest, and those were exploratory outcomes, so not primary endpoints, but amino acid formula with symbiotics did result in reduction of parent-reported vomiting, spitting up, and bloating. There was less dry stool and constipation, and this particular study was a study that investigated extensively hydrolyzed formula. But also with the amino acid formula with symbiotics, there was improved stool consistency, stool color, again, making it more similar to the stool of healthy breastfed infants. And importantly, there were fewer infants who needed drugs for functional gastrointestinal disorders. So there is a indication that hypoallergenic formulas with symbiotics have a beneficial effect on the gut health in those infants. So those were the randomized clinical trials. Now moving on to the real world evidence. And those were, there was a clinical study comparing amino acid formula with symbiotics and without, one meta-analysis, as well as another real world study with the extensively hydrolyzed formula. So all of the studies focusing on real world evidence confirm previous observations. So there were reduced clinical symptoms or reduced infections and medication prescriptions in infants fed with amino acid formula with symbiotics. And in that particular study, which had 50% of infants with cow's milk protein allergy fed with symbiotics, 50% fed with traditional formula without symbiotics. Those infants fed in the symbiotic group had lower rates of all-cause clinical symptoms, infections, and medication prescriptions with a highly significant p-value. They had also lower rate of all-cause healthcare contacts among infants, although this wasn't statistically significant, but definitely had fewer gastrointestinal, skin, and respiratory symptoms, fewer overall infections, gastrointestinal, skin, and respiratory, as well as ear infections, and also higher probability of achieving 3 or more symptoms, a month of no symptoms, and no need for hypoallergenic formula prescription later on. So in a systematic review, you can see in a graphical form that 3 clinical trials that were conducted in infants with cow's milk protein allergy, both IgE and non-IgE mediated. There was a consistent protection from infection in this forest plot, which is moved towards favoring protection from infection. So that's, even though this was not the primary endpoint of the study, it did confirm this beneficial effect of adding symbiotics to amino acid formula. And finally, the most recent study published this year that was a single-arm prospective study that looked at the extensively hydrolyzed formula with symbiotic and investigated caregiver quality of life, formula acceptability, safety, and hospital-related healthcare use. So those are the real-world endpoints outside of the clinical trials. It was a smaller study. It involved 29 infants with non-IgE mediated cow's milk allergy, and the caregivers reported significant improvements in quality of life after use of the formula with symbiotics, comparing to pre-initiation of formula feeding. They did report a better enjoyment associated with caring for their infants when compared to baseline formula. And importantly, there was significant reduction in mean number of overall hospital visits that was observed in the 6-month follow-up period compared to 6 months prior. And the largest decrease was for elective hospital attendances, suggesting that formula with symbiotics does have a long-lasting or persistent protective effect, not only in the comfort, reduction of gastrointestinal symptoms, but also the beneficial protection from the infections in those infants at risk. So in summary, a new generation of hypoallergenic, both extensively hydrolyzed and amino acid infant formulas with symbiotics replicates the immunomodulatory effects of breast milk. So definitely we are observing beneficial effects of the new generation of formula. Those formulas with symbiotics promote colonization of the infant gut with beneficial bacterial communities, making it more similar to the communities observed in the gut of healthy breastfed infants. And as secondary outcomes, but multiple studies have shown that formula with symbiotics have a consistent protective effect from infections in early life also observed in the latest real-world evidence in infants with cow's milk protein allergy. And for that particular patient population, this is protective effect is of special relevance because they have a compromised immune system and they are overall predisposed to infections due to Th2 skewing of the immune responses and lower capacity to protect themselves from infections. So I think altogether the evidence from multiple studies does support the beneficial effects of the formulas with symbiotics in management of cow's milk protein allergy in infants, and it's providing safe alternatives to the traditional formulas without symbiotics. Thank you very much for your attention.